Onc Live Insights is a video editorial program produced by Onc Live.
So let's move on to talk about adverse events now. Maybe we could take it by class, starting with the IMiDs.
So the most common adverse events we see with the IMiDs, and I'm going to focus predominantly on LEN and POM, because I think THAL is really not utilized a lot in the U.S. any longer. And their AE profile is pretty similar. Myelosuppression is the most common one we see, neutropenia, thrombocytopenia, some level of anemia with both those drugs. It may be worse in patients with renal insufficiency, and that's why dose adjustment, certainly of lenalidomide, makes sense, and probably to a certain extent with pomalidomide until we have more data makes sense as well. Other adverse events can include fatigue, we see that a little bit, and then the risk of thrombosis. And oftentimes an aspirin is sufficient to mitigate that risk for patients who are immobile or who are getting other risk factors like ultra-high dose dexamethasone or combinations with anthracyclines. They often may need full-dose anticoagulation in that context.
And when you dose reduce in the cases of pomalidomide and lenalidomide, is there a compromise in efficacy, or you're able to maintain it?
Yeah, I think for the most part you can maintain it because it's a matter of renal clearance and because the drug is being cleared slower in patients with renal insufficiency, particularly with lenalidomide. I'm not so sure that applies with POM, to be honest with you. We just don't have all the data. But my sense is that POM is probably less influenced by renal function than lenalidomide is. And so in that sense, you're getting the same effective dose.
Let's talk a little bit further about adverse events and what role that plays in making decisions. Sounds like there's a plethora of options in refractory multiple myeloma. Talk a little bit about the differences in toxicities and how you manage those in your clinic.
So that becomes very important, and especially when you have choices, you want to, have an efficacious drug, obviously, but at the same time, you want to be able to minimize toxicity a lot. So that goes into how I end up choosing what I choose for the treatment. I talked a little bit about, when I would choose what in certain situations. Drugs like pomalidomide, I said, the biggest toxicity that we worry about is myelosuppression. Having said that, in the relapse setting, sometimes if you come up with the right supportive care approaches, you're actually going to be able to circumvent some of those toxicities. So understanding the toxicities and kind of preempting them and preventing them is also helpful. I will use growth factors in my practice, at least initially, when you want to get the drug in to control the disease. And then over time, you can back off on using some of the Neupogen that you ended up using initially. Infection can be a problem because of the neutropenia, sometimes with, not just with one or the other drug. That's a problem with myeloma in general. They have a fair amount of immune paresis. They are prone to all kinds of infections. So you will see it not necessarily with one or the other, but you're going to see it with all drugs. So simple things like everybody should be prophylaxed with the routine vaccines, flu vaccines. We do tend to use prophylactic antibiotics. When you're using a proteasome inhibitor, we do use acyclovir for shingles prophylaxis. If you're using dexamethasone a lot in your regimen, I would recommend PCP prophylaxis as well with Bactrim. We have a low threshold to treat with antibiotics. Occasionally, if you have patients who come up with repeated infections, we have used intravenous immunoglobulin also to support them. So that's mainly pomalidomide. I don't think neuropathy is a big issue with pomalidomide. With the proteasome inhibitors, with carfilzomib, for example, it is an IV formulation given 2 days in a row, 3 weeks in a row. We have seen some issues around fluid retention, but I do think if the drug is given slowly, if you don't mandate kind of necessarily all the pre-hydration and the post-hydration, you can come around that and you can safely use these drugs because these drugs are good and they do work. So it's more about understanding the toxicity and managing that toxicity. Because end of the day, I will tell you, Joe, that all myeloma patients are going to see all of these drugs at some point in time in their lives. And the better we understand the toxicity and the better we know how to manage that toxicity, I think, is in our patients' best interest, and we be able to keep patients on drugs longer. Besides that, with carfilzomib, besides the fluid issues, I don't think there is really no direct cardiac toxicity. It's more fluid overload, and once that's managed, you can keep patients on that. With some of the newer drugs, we'll have to wait and see because they're still very early in development. So, we need better formulations. We need them to be better tolerated by the gut, not having a lot of GI toxicity, because it doesn't make sense being on an oral drug and then being on a whole lot of antiemetics so that you're tolerating them, or getting IV fluids to counteract the action of an oral drug. That kind of defeats the purpose. So that's something we're still learning as we speak.
How about in cases of elderly patients or patients with pre-existing conditions or renal impairment? What's your experience in the tolerance of pomalidomide?
We have used pomalidomide in all of those settings, Joe. We have used it in the elderly patient population. We have used it in patients with comorbidities, whether they have cardiac comorbidities, renal issues. Every single patient who has relapse refractory myeloma is a candidate for pomalidomide. We've used it in many, many different patients. Right now there are no dosing guidelines for renal impairment. In the studies, patients who had severe renal impairment were excluded from the trials, but we have safely used this drug even on patients who are on renal hemodialysis. So again, we have used it in doses that may not be 4 milligrams, but every case is decided on an individual basis based on the clinical status of the patient. But again, we've used it safely in elderly patients and other comorbidities. If a patient does present with impaired renal function or other comorbidities, we are of course monitoring those patients more closely. We may want to see them more frequently, maybe give them a call. The nurse navigators call them up, see how they're doing, maybe monitor not just their CBCs, but their chemistries more frequently, just to keep a closer eye on them if they have other comorbidities or if they're elderly.